Good morning. I'm Doug Wood. I'm the Chief of Cardiothoracic Surgery at the University of Washington, and I'm joined this morning with Dr. Dave Mattis, who will be speaking right after me, who's the head of our lung cancer screening program. And we're going to be talking with you about lung cancer screening, some of the aspects of the development of guidelines and policy, but then the practical aspects of which patients should be referred for lung cancer screening, how to get them in for screening, and how they're managed from there. So one of the important things to always start off when we're talking about lung cancer is to re-emphasize what a dominant public health problem lung cancer is. Lung cancer is by far the most common cause of cancer death in the United States. It actually exceeds the next four cancers combined: colorectal, breast, pancreas, and prostate. And in fact, the sixth most common cause of cancer death is lung cancer in never smokers. We're not going to be talking about never smokers today when we're talking about lung cancer screening, but this is really to emphasize what a dominant problem lung cancer is and why screening is important. And when we talk about screening or early detection in lung cancer and consider other common cancers that currently have screening, you can see that there's screening programs we all understand for breast, prostate, and colon. And when we look at survival rates and stage at which cancers are detected, you can see that breast cancer, prostate cancer, and colon cancer have much higher rates of early detection of localized disease, that is, disease at a time that it can potentially be cured, whereas lung cancer almost always is detected at a later stage. And again, this related to the fact that disparities, that lung cancer occurs more commonly in the elderly, affects lower socioeconomic groups, has worse outcomes in underrepresented minorities, and has the stigma of being a self-inflicted disease. And if we look back just 6 years ago to the NCCN guidelines, the NCCN at that time recommended that there should not be CT screening for standard clinical practice because of conflicting data. And the reason for that is, although numerous studies had shown that you could identify cancer at an early stage and improve resectability and survival in individual patients, it was not clear that lung cancer screening was going to improve mortality in a population overall. And there had been no randomized trial and no appropriate control group. And in fact, as a randomized trial is very difficult to perform in this type of disease process. And all the problems exist of overdiagnosis bias, length or lead time bias that are common problems when we have non-randomized studies looking at screening. But many of you are aware then of a very large randomized clinical trial, the National Lung Screening Trial, that was recently completed. And this has really changed the game for lung cancer screening. To briefly review the background of the trial, this was a randomized controlled trial that randomized over 53,000 patients to a low-dose CT scan versus chest X-ray. Chest X-ray chosen as the control group, not because it was standard of care, but because it's hard to conduct a randomized trial without some other intervention for the control group. These patients were 55 to 74 years old, had at least a 30-pack year smoking history to be eligible for the trial. And this was to try to pre-select a high-risk group for lung cancer. The trial started in 2002, randomized patients up until early 2004, and then continued 3 screens that extended until 2007. And this led to ultimately an early closure of the trial in 2010, with the Data Safety Monitoring Board noting a very positive result in the trial that I'll point out here a 20% mortality reduction from lung cancer in patients that had CT screening compared to those that had a chest X-ray alone. And this is really a very significant difference, a significant outcome, and is the reason that the trial was closed from further evaluation and was published in the New England Journal of Medicine in 2011. And the final conclusion of the National Lung Screening Trial is that screening with low-dose CT conclusively reduces mortality from lung cancer in high-risk patients. This led to a number of groups working on guidelines of lung cancer screening, and the National Comprehensive Cancer Network, one of our largest guidelines group for cancer care, was the first to publish guidelines after the publication of the National Lung Screening Trial. This was published in 2012 in the Journal of the National Comprehensive Cancer Network and was made up of a panel of wide variety of expertise from thoracic radiologists, pulmonologists, internal medicine, patient advocacy, epidemiology, thoracic surgery, etc. This is very easy to review online. The NCCN guidelines are online and accessible to all providers. I'm just showing you examples of that, and this shows the breadth of the panel, individuals from 26 separate major cancer centers around the United States, representing a wide variety of specialties and expertise. And the probably key page of the guidelines are these that show patients that are at high risk for lung cancer, these at the top part of the algorithm, that would be recommended to undergo lung cancer screening, and those at moderate or low risk of lung cancer that would not be recommended for routine low-dose CT screening. But a very important aspect of lung cancer screening is not just detecting which patient should have it, but what to do with them after they're screened. Because one of the concerns about screening always is what is the impact of false positives and the unintended consequences of additional testing or other workup that could actually produce harms for patients that are otherwise healthy. So one of the things that the NCCN panel did is provide guidelines for how to manage lung nodules that are detected, to try to provide an algorithmic, disciplined management of different size and different character lung nodules to try to help avoid unnecessary workup or unnecessary invasive testing. And there's different parts of this algorithm for solid nodules, and now the increasingly identified non-solid nodules or ground glass opacities that we frequently are detecting when we're getting low-dose CT scans in this group of patients, and ways of manage them if they're stable or if they're increased in size over time. And there's also an algorithm for what to do when there's a new nodule or suspected infection or inflammation, and how to manage that patient, follow that patient until the nodule is either diagnosed or has resolved. And I've purposely blurred this slide because we're in the stage of developing new guidelines for lung cancer screening, at least new algorithms, because the American College of Radiology has developed LungRads, which is a standardized reporting system for lung nodules, standardized reporting and management system that has been modeled on BI-RADS, which has long been used for mammography and breast cancer screening. And the NCCN and the American College of Radiology have worked together to harmonize our nodule management guidelines. And so the NCCN guidelines that will be republished soon as they're updated each year in 2017 will have some revisions of the nodule management that will make them harmonized with the LungRads, so that there's not any confusion or areas of discrepancy in management for practitioners. Part of the NCCN guidelines also have a list of risks and benefits, and this is to help inform both patients and their physicians and providers on aspects to talk about when shared decision-making is taking place. One of the strengths of NCCN guidelines is that they are often, and in this case have been also converted into guidelines for patients in lay language. And this is also available on the website for your own patients to review and be informed on lung cancer screening. So with all of the guidelines being developed, the most important component of guideline development is what the United States Preventive Services Task Force, or USPSTF, would recommend, since that, of course, is the national organization that has the weight of law behind it in terms of validating and requiring coverage for preventive services in the United States. And on December 31st, 2013, the USPSTF did recommend lung cancer screening for high-risk individuals, and so this is available at the USPSTF website as well. What is somewhat paradoxical is that although the USPSTF had recommended lung cancer screening, and this requires, under the Affordable Care Act, coverage of lung cancer screening by all private insurers, Medicare has its own process and is not required to follow USPSTF guidelines. And in fact, this is pretty important because 70% of initial diagnosis of lung cancer is in patients that are Medicare beneficiaries. But a long process went on with multiple individuals working with Medicare administrators to educate them also about the data and the policy implications of lung cancer screening. And in fact, Medicare also approved low-dose CT scan for lung cancer screening on February 5th of 2015, so just a little over a year ago. So if we review where we stand, a low-dose CT has now been established to have a significant mortality benefit for lung cancer screening. USPSTF recommends it, and that makes it a required benefit of private insurers under the Affordable Care Act. And Medicare is now providing coverage for beneficiaries as well. And as someone who's been treating lung cancer my whole career, this is probably the biggest impact in lung cancer management than anything else that we've done in at least a generation. It's more significant than improvements in surgery, in new technical advances in radiation therapy, and even in new therapies with systemic therapy or chemotherapy. And this really shows why. If we look at the graph on your right, this is the standard survival of lung cancer patients currently and historically. But the curve on your left is survival of a group of patients with screen-detected lung cancers in the International Early Lung Cancer Detection Project. And this is a large number of patients recently published with an almost inversion of outcomes, with the historical survival being about 16% over 5 years, and the survival in screen-detected lung cancers being approximately 84% in 5 years. So really a huge difference in potential outcomes for patients who have screen-detected lung cancer. And many ask about the efficiency as well as concerns about the unintended consequences of screening. And screening with low-dose CT for lung cancer, the number needed to screen is a number that we often use when we're talking about screening efficiency. This is the number of people that would need to be screened to save one life from that cancer. And you can see that, in fact, lung cancer screening is 3 to 5-fold more efficient in terms of number needed to screen than either mammography or screening colonoscopy. So really a very effective screening tool compared to other frequently used screening tools. And when we look at guidelines that have now been developed further in the United States and beyond. And some aspects of them, the USPSTF and Medicare, I've put here on the left. These are the Canadian organizations, NCCN that we've been talking about, American Lung Association, American College of Chest Physicians, American Academy of Family Practice, one of our surgical societies, and the European Respiratory Society. All of them have come out in favor of lung cancer screening, except for the American Academy of Family Practice, which is the sole organization to date that has recommended against lung cancer screening. So there are many issues debated in lung cancer screening, and we're not going to go over all of them. But one of the issues that has certainly I have felt compelled to emphasize is the aspect of lowering barriers to access. And this relates to a 2015 American Cancer Society challenge goal to eliminate disparities in the cancer burden among different segments of the U.S. population, defined in terms of socioeconomic status, race, ethnicity, geographic location, sex, and sexual orientation. And this is a place where I think lung cancer screening is really paramount because of what I mentioned at the beginning of this, that lung cancer patients are older, have higher mortality amongst African Americans, lower socioeconomic groups have a 4 to 5 times greater mortality, and there's aspects also with rural access to screening and treatment. So I think there's no other area, certainly in cancer care, that there are such clear disparities and an opportunity to address those disparities with standardized early detection. Thank you very much.
Good morning. I'm David Mattis. I'm the director of the Lung Cancer Early Detection and Prevention Clinic at the Seattle Cancer Care Alliance, and also director of the CT screening program for the Seattle Cancer Care Alliance and the University of Washington. I'd like to build on the background that Doug has very nicely laid out for you to talk about the practical aspects of CT screening in our particular screening program. So the Seattle Cancer Care Alliance launched its lung cancer screening program in 2012, and we follow the criteria set out by the guidelines of the United States Preventive Services Task Force, CMS, and also the National Comprehensive Cancer Network. Our scan protocol is to have one scan at baseline and then annually, as long as the individual continues to meet the guidelines. Our service delivery points are as follows. The patient is identified by the medical provider or can self-refer for screening by contacting the Seattle Cancer Care Alliance Lung Cancer Early Detection and Prevention Clinic. The low-dose CT scan is performed at the Seattle Cancer Care Alliance, and the scan is interpreted by University of Washington thoracic radiologists, and they use a structured reporting format that provides guidelines for the ordering provider as to next steps to take in evaluation of the findings. Those individuals who have scans concerning for possible lung cancer can be referred to the Lung Cancer Early Detection and Prevention Clinic at the SCCA for a diagnostic workup, and patients who have newly diagnosed lung cancers can be referred to the SCCA University of Washington Thoracic Oncology Program. Since opening the program, our screening program, in January of 2012, we've enrolled now up to the end of March 362 individuals, and we've detected 6 asymptomatic lung cancers, including 4 non-small lung cancers and 2 small cell lung cancers. When thinking about referring a patient for CT screening, it's important to think about the coverage and cost of the screening scan. And so, as Doug has mentioned, Medicare and Medicaid has made the announcement back in January of 2016. Well, actually, the announcement was in February of 2015, but coverage beginning in 2016 with 2 new CMS codes. One is G0296, and this is coverage for the shared decision-making counseling that can be held as a separate visit with the individual, or it can be added as a part of an E&M code or annual wellness visit using modifier 25. There's no cost sharing for this shared decision-making counseling with the patient. Then the code for the CT scan itself is G0297, and again, there's no cost sharing with the individual. It's important to point out that both of these G codes need to be linked to an ICD-10 code for personal history of tobacco use or nicotine dependence. This is code Z87.891. Private insurance also covers individuals for lung cancer screening who are between the ages of 55 and 80, have a greater than 30-pack year or more of smoking history, and have quit within the last 15 years or are current smokers. Cost of this is covered under the Affordable Care Act with no cost sharing with the individual. And the CPT code for this order is S8032, and this has been in effect since October of 2014. I want to point out that shared decision-making counseling is endorsed by the United States Preventive Services Task Force, but is not required. And currently, private insurance does not cover the cost of the shared decision-making counseling visit. Those individuals who are not covered under insurance, the cost of the uncovered CT scan is $300, and any abnormalities that are found on screening exam are covered by third-party payers. When talking to patients about CT screening, it's important to advise them of both the risks and the benefits. The risks that I emphasize in counseling these patients are the radiation risk. Low-dose CT scans have a radiation exposure of between 0.6 and 1.5 millisieverts for the average size individual. And this compares to a routine chest CT scan that has a radiation dose of between 5 and 8 millisieverts. And the difference between these two is the need on a routine or diagnostic CT scan to use higher radiation to better visualize the mediastinal structures. When I talk with my patients, I give a comparison of what's the naturally occurring radiation exposure in the United States at sea level, and that's 3 millisieverts per year. For comparison purposes, the radiation exposure for mammography is 0.4 millisieverts, and for a head CT scan is 2 millisieverts. The second point I'd like to discuss with the patient is the anxiety risk. And this is anxiety that could be due to uncertainty of a positive screening test, or it could be the discovery of a significant incidental finding. The impact of lung cancer screening on anxiety or the quality of life and state anxiety was explored by the National Lung Screening Trial. And this cohort was evaluated for health-related quality of life and state anxiety at baseline scan, and then at 1 and 3 months after the baseline scan. And the results were analyzed by categorizing individuals by the result of the scan as either a false positive, a negative, or a significant incidental finding, or a true positive result. And as you can see in the plots here, this is the physical component score of individuals at 1 month following the baseline scan. And you can see for a false positive scan, a negative scan, or a significant incidental finding scan, there was no significant impact or change in the health-related quality of life. And the same was true also at 6 months after the baseline scan. This was true for the physical component score as well as the mental component score. However, individuals who had a positive finding on the scan, meaning they were diagnosed with lung cancer, there was a significant decrease in the health-related quality of life. As also down here, we look at the state anxiety scores. Once again, we see for individuals who had a false positive baseline scan, a true negative scan, or a significant incidental finding at baseline, that there was no change in the state anxiety at 1 month or 6 months following that baseline scan. But once again, individuals who were diagnosed with lung cancer did have an increase in their state anxiety. So the authors concluded that fear of undue anxiety should probably not dissuade providers from screening high-risk patients. A third point that I'd like to mention when discussing counseling with patients, and that is the complication risk. And so the National Lung Screening Trial showed that for a diagnostic procedure on a positive screening CT scan, the risk of a complication was 1.4%. And then finally, the financial risk for those individuals who are not covered under Medicare, Medicaid, or private insurance. It's the cost of the screening CT scan, which at our institution is $300, and that represents the national average. I also like to counsel the patients with the potential benefits of lung cancer screening, which is the 20% reduction in death from lung cancer compared to a routine chest x-ray or usual care. An estimated 12,000 American lives saved annually, and this is also a teachable moment for smoking cessation counseling. For those of you who are on Epic Care, you would have noticed that beginning in November, there was a new health maintenance topic for lung cancer screening that became available. This is an alert that is that pops up on the in the record for those patients who are between the ages of 55 and 80 and have any tobacco smoking record. And this is intended to be a prompt for you as the provider to explore with the individual their risk factors for lung cancer and whether they would qualify for a screening CT scan. Now, it's important to emphasize that CMS requires shared decision-making counseling with the individual before performing the lung cancer screening exam. And they require that this lung cancer screening counseling and shared decision-making be an in-person visit by a physician's assistant, a registered nurse practitioner, or a certified nurse specialist, and that it would include the use of a shared decision-making aid. And in a moment, I'll go over what some of those are. The U.S. Preventive Services Task Force, in their final guidelines on lung cancer screening, recommend but do not require a shared decision-making conversation. But they recommend that this be a thorough discussion of the possible benefits and limitations and the known and uncertain harms that could result from lung cancer screening. So there are a number of available decision-making aids that you can access online. I wanted to show you 3 of those. One is a decision-making aid produced by the American Thoracic Society. This is an electronic brochure that you or your patient can download at the web address at the bottom of the slide. And basically it walks the individual through what are the components of lung cancer screening, the eligibility requirements for lung cancer screening, the potential risks and harms, and provides the individual with a sort of background that can then be taken to the primary provider for further discussion about the pros and cons of lung cancer screening. A second shared decision-making aid is provided by the American Lung Association. This is accessible at the web address at the bottom of the slide. And basically what this does is it walks the individual through a series of questions which will categorize the individual as either eligible under CMS guidelines or U.S. Preventive Services Task Force guidelines, and will allow the individual to print out a sheet that demonstrates their eligibility and also lists some questions that they should bring to the provider in discussing the pros and cons of lung cancer screening. And then a third website, which I find particularly helpful, is provided by the University of Michigan, and it's accessible through this link at the bottom of the slide. And basically, it directs the individual, or you as the provider, to go through a series of 12 questions which risk profile that individual for lung cancer and determines their eligibility for lung cancer screening. And the display that is produced then from this website, based on the individual results of that patient, is their risk for developing lung cancer over the next 6 years, and it's shown in this sort of heat map display right here. It also provides a little description of the potential benefits of the individual for the lung cancer screening as well as the harms. So we are in the process now of developing a smart set of orders in Epic that providers can use to order and track individuals for lung cancer screening. And this smart set will include a shared decision-making counseling template. This template will have information self-populating for the patient's age, and then you would fill in information about smoking status, pack years, if they're a former smoker, the year that they've quit, and any signs or symptoms of lung cancer. It then provides a portion of the template for how you've participated using a shared decision-making tool in the conversation with the patient. And it also outlines a text that you can use to talk with the individual about the potential benefits, the potential harms, and then items of counseling that you should think about with that individual patient. Perhaps it's the counseling of importance of cigarettes smoking cessation or maintenance of abstinence. It could be the importance to emphasize the adherence to annual screening, and also to have the individual understand and be willing to undergo invasive procedures or treatments in the event that there are concerning findings for lung cancer. Those 3 websites that I mentioned to you for the shared decision-making aids can be found at our website for the Seattle Cancer Care Alliance low-dose CT screening program. I also want to emphasize that our screening program is one of 4 in the state of Washington that have been recognized by the Lung Cancer Alliance as a screening center of excellence. And this means that we have met a rigid criteria in the way we've developed our program and for the multidisciplinary management of findings based on those CT scans. Now, in order to order a low-dose CT scan in Epic, you can just type in the text CT scan low-dose screen, and that will provide this screenshot for the order. On this order form, there are 3 questions to be addressed. One is whether the patient is a current smoker. If they're a current smoker, would they like to receive smoking cessation counseling? And then finally, it asks the question, do they meet the criteria of the U.S. Preventive Services Task Force for CT screening? Now, I want to advise you that this order is under revision by our Epic IT group and myself, so that we'll include also the CMS criteria for screening down in this bottom dialog box. So what then is the anticipated distribution of outcomes that we could anticipate for individuals going through a CT screening program? This algorithm here is based on the results of the National Lung Screening Trial. But if we have a theoretical 1,000 patients who undergo CT screening, we would anticipate that 2/3 of them would have a negative scan, and they would simply return for annual low-dose CT screening. 10% of individuals would have an abnormal CT scan, but it's not suspicious for lung cancer. These individuals would be referred back to their primary care provider for the management of those incidental findings. And then the balance of the individuals, which could be anywhere between 13 and 24% of those scanned individuals, depending on the cutoffs for what's considered to be a positive result, will have findings concerning for possible lung cancer. And of those individuals, there will be 20 individuals over a 2-year period of time that will be diagnosed with lung cancer based on the results of the National Lung Screening Trial. So as Doug alluded to, there are 2 different organizations which have developed guidelines for nodule management. The first of these is the American College of Radiology with their LUNG-RADS assessment score, or categories, for lung nodules that are perceived in individuals at high risk for lung cancer. There are 4 categories that are defined based upon the morphologic appearance of the nodule as well as its size. This is on the baseline screening scan as well as the subsequent screening scan. And based upon which category those findings fall within, the guidelines provide recommended further workup, which we'll come back to in a moment. Similarly, the National Comprehensive Cancer Network has provided guidelines, which Doug showed you just a moment ago. And then based upon the radiographic appearance of the abnormality, if it's solid or part solid, as well as the size of the nodule, will determine the recommended pathway for management of those abnormalities. Similarly, for ground glass opacities or non-solid lesions, there is a different pathway for management of the nodule. And so for those individuals who have a CT scan that's concerning for possible lung cancer, The workup could include a repeat low-dose CT scan at a short interval of 3 to 6 months. It could include a non-invasive imaging workup, such as a PET scan, or it could include an invasive workup, which might consist of either advanced bronchoscopic techniques, such as endobronchial ultrasound or navigational bronchoscopy, CT-guided percutaneous biopsy, or surgical biopsy or resection. And out of these workups will then come the diagnosis of lung cancer in 20 of the 1,000 patients over a 2-year period of time. So this can be the nodule management can be performed by individual providers if they so desire, but this can be a lot to track over an extended period of time. And so an alternative would be to refer your patient to the Seattle Cancer Care Alliance Lung Cancer Early Detection and Prevention Clinic, where we're able to evaluate these nodules, make recommendations for appropriate testing, and follow them through the entire pathway for their nodule evaluation. The Lung Cancer Early Detection and Prevention Clinic was launched at the Seattle Cancer Care Alliance in 2008, and we received referrals from the University of Washington neighborhood providers, from the University of Washington Medical Center, from the Seattle Cancer Care Alliance oncology clinics, SCCA network partners, and other community partners. And the referrals that we are receiving are positive screening CT scans or incidental pulmonary nodule evaluation. The clinic consists of 2 components. The first is the nodule board, and the second is the clinic itself. Our lung nodule board is staffed by pulmonologists, thoracic radiologists, thoracic surgeons, medical oncologists, and smoking cessation specialists. And for a given clinic day, we will, as a group, review the imaging of patients to be seen in clinic that day and come up with a tentative plan for management of the lung abnormalities. Then the patient is seen by the pulmonologist in clinic, and we refine that plan for further evaluation. Further evaluation may include pulmonary diagnostics, such as advanced bronchoscopic procedures, interventional radiology for CT-guided percutaneous biopsy, or our help from our thoracic surgery colleagues with lung biopsy. Individuals who are found to have lung cancer are then referred to medical oncologists, thoracic surgeons, or radiation oncology for further management of the lung cancer. In order to make a referral to our Seattle Cancer Care Alliance Lung Cancer Early Detection and Prevention Clinic, in EPIC you would use the search term referral to pulmonologist, and that will give a drop-down box of all the pulmonary clinics in the University of Washington system. You would select the SCCA clinic, pulmonary clinic, and when you click on that line, you get a second drop-down box which identifies Lung Cancer Early Detection and Prevention Clinic, or on the second line, Lung Nodule Clinic. Either one of those will work because they both come to our Lung Cancer Early Detection and Prevention Clinic. So how to contact us then? So this slide shows the web address where you can reach us at the Lung Cancer Early Detection and Prevention Clinic. Also, these search terms in EPIC will provide referrals over to us. You can contact our patient care coordinator, Shatreen Masur, at these phone numbers. And the providers in the clinic include myself, Dr. Guangxing Chen, Dr. McGarry Houghton, Dr. Lisa Vandavasi, and our nurse practitioner, Maggie Guaro. So in summary, lung cancer screening does save lives. Medicare and Medicaid and the U.S. Preventive Services Task Force recommend CT screening in high-risk individuals. The cost of CT screening is covered at no cost sharing with the patient for those who qualify. And I want to emphasize that CT screening is really a process rather than an event. And successful screening requires an engaged patient and provider, plus an integrated CT screening program such as the one we have through the University of Washington and Seattle Cancer Care Alliance. And finally, I want to emphasize that smoking cessation remains the #1 method for lung cancer prevention. And with that, I would like to thank you for your attention.